Hey guys, ladies, good afternoon, everyone. Um, Thanks for tuning in to this session. Would like to have it interactive as much as we can. So if you feel that you wanna throw an idea or have a question while we're chatting, please feel free to do so. Uh, I really don't have a dedicated topic that I'm going to talk about today. However, there are some very important questions that came to us from you guys, and we'll try to answer them and in a context where we'll give an idea about what's going on and try to answer the question as needed. Obviously, everything's going to be according to guidelines and individualized therapy and my 10, 12 years of doing this business. The first question is important one. I think Crystal asked that. It's about using Midodrine to allow the use of Entresto, and we're totally against that. We are totally against that. Why? Because you use Entresto as afterload reduction medication to allow the heart to remodel and decrease the stress level on the walls of the heart by what we call afterload reduction, vasodilatation, right? So if you're going to use Midodrine, you're defeating the purpose by doing vasoconstriction, increasing the afterload. So you're increasing the afterload, and at the same time, you're trying to decrease the afterload by doing Entresto. So that's really not a good idea at all, right? Similar to when you have right arm heparin infusion and the left arm blood transfusion, the same concept. So we really don't like that. Now, uh, areas we can use Midodrine in heart failure patients. If your patient is really hypotensive and tachycardic, you would like to use some beta blockers, but you would like to have a little bit high blood pressure to be able to utilize the beta blockers more. In that case, you can do Midodrine and you can do beta-1 selective beta blockers, such as metoprolol, toprol XL, or bisoprolol. So in cases like that, it's really acceptable. You have AFib and your AFib patient in the ICU or your AFib patient in the nursing home or wherever, and they become hypotensive but tachycardic at the same time. You rule out, let's say, bleeding, or you rule out sepsis, and you rule out other aspects, and this is the patient baseline. In that case, it's really acceptable to use AV nodal blocking agents and to allow a little bit of blood pressure so you can utilize the AV nodal blocking agents. You can use Midodrine in these cases.
What about diuresis?
Absolutely, yes. That's another concept. Very, very good point. You can use Midodrine to give blood pressure, and you can diurese patient. Similar to when we actually do, let's say, dopamine or dobutamine and diurese your patients. That's also acceptable. So we can use Midodrine in these cases. It's going to be a little bit stress on the heart, but it is what it is. Remember, when you do stuff like that, you may use it for a short period of time, and always give intervention. As we said, the art of medicine, you do intervention and you see how your patient respond to it and adjust accordingly. Any questions about that?
No.
Okay. So in terms of loop recorder removal, if the battery is if the battery is dead, it's really up to the patient. You know, demented patient, bedridden, I wouldn't bother. The material is titanium, which is similar to the hip, similar to any kind of body-friendly metal that is not going to cause any reaction. And leaving loop recorders in patients is totally acceptable. All loop recorders we have right now, at least for the last 10 years, they are MRI compatible, so it should not be an issue. Okay. So now, if you have atrial fibrillation patient, you have chest VAS score is high. The question is going to be if you have HAS-BLED, i.e., if your patient is high risk of bleeding, what would you do? Well, number one, you have the Watchman device or amulet devices that we can utilize. Now, if your patient is bedridden and, nursing home patient, you're trying to be very conservative. always remember that if your hemoglobin above 8 and your high bleeding risk, I would utilize anticoagulation such as Eliquis, and try to identify the response of Eliquis. Like, let's say a patient has history of um, GI bleed in the past. Patient hemoglobin today is 9.5, diagnosed with atrial fibrillation, CHA-2DS score of 5, is unethical to say that a patient has high fall risk or patient contraindication for anticoagulation. Because, you know, these strokes coming from the left atrium, in the case of atrial fibrillation, they tend to be massive. I tell my patients that the heart is very big blood vessel, and strokes, clots coming from the heart, they tend to be massive. So you really make no mistake, be very careful. I'll tell you a story. One of the patients that is Steve on with us? Steve, are you with us, Steve? Okay. So lady who knows Steve came to me, age 93 years old, wonderful lady. I interrogated her device. She had atrial fibrillation. She has VAS score about 4 or 5 at that time. So it's high. So I told myself a little bit of paroxysmal AFib. You know, I'm going to try to educate this elderly lady about anticoagulation right now, or drag her to the hospital for Watchman device implant. So I didn't start anticoagulation. 3 months later, I got a phone call from the hospital that she had massive stroke. I've never seen her again. So I probably she died now. So I really regret not introducing anticoagulation. So always, even the CHA-2DS score is high, hemoglobin above 8, do trial of anticoagulation and see how your patient can respond to that. Hemoglobin went down to 7, patient start having bleeding issues, patient's not candidate for Watchman or amulet, then, you know, hey, at least document in your chart that patient really cannot handle anticoagulation. Don't assume that your patient is just cannot handle anticoagulation based similar to any other, you know, primary care or some Joe Schmo cardiologist or whatever. You really need to do your best to prevent stroke in this patient population. And now if your hemoglobin 7.5, then really document in your chart that, you know, patient is chronically anemic, anticoagulation is contraindicated. I wouldn't recommend aspirin though. Aspirin in the latest guidelines, 2021 AFib guidelines, HRS, ACC, AHA guidelines, there's not a mention, not a single word about aspirin. So aspirin and AFib, you know, don't combine. In other words, don't do this, you know, intervention cardiologist or the primary care physician, the aspirin business. Do not use aspirin in the case of atrial fibrillation. Has no role. Fair? All right.
What about using low dose, even when patients don't meet criteria for it? I see that all the time.
For AFib?
For AFib.
Has no impact, has no, Europeans are much smarter than us. In their guidelines in 2016, no aspirin. And we fast forward 5 years.
No. Low dose like Eliquis or Xarelto, even if they don't meet criteria for low dose.
Look, there was a study said that if you do the low dose that's not accepted for age, weight, and creatinine, your hazard ratio is 4, i.e. 3.9 during that study, so about 4 times. I don't know. I mean, I don't like that. I mean, I get it. I've used it, right? I've used it. I would rather for you to start with the what FDA approved, and if you want to trickle from that down a little bit, you know, your hemoglobin was 9.6, went down to 8.5, then in that case do 2.5 twice a day and see how you do. But there's really huge advocacy and huge insistence, or there is some kind of education about the fact that 2.5 twice a day of Eliquis is not anticoagulation in this patient population. So be very careful.
Okay, that's how I felt too. I had a primary argue with me that she didn't feel comfortable with it. So I just wanted to make sure I was right.
I had to pull the data one time in a structural heart meeting with a bunch of very smart, educated cardiologists. that guys, we don't, you know, if you're not, that's not standards of care, and that's not FDA approved stuff, and we're not going to do it. There's actually data about that, and there's actually a huge education against this, you know, little bit of you satisfy yourself, but you don't treat your patient. That's not good. So be careful about that. All right. We talked about that multiple times before. So aspirin and antiplatelet agents in the setting of CAD. No dual antiplatelet agents beyond 1 year of MI or stenting. Okay. If it's up to me, no anticoagulation, dual antiplatelet therapy beyond 6 months. Okay. And for your elderly patients, you do dual antiplatelet therapy for 3 months and just use single antiplatelet agent afterwards, after stenting or MI. Okay.
Yeah, same after cabbage.
Cabbage, you just antiplatelet agent, just aspirin. Yeah. And if you look at the guidelines, they say 162 or 325, but nowadays even 81 is acceptable. So go ahead.
What about if the patient has residual disease? Do you recommend?
Doesn't matter. It doesn't make any difference, to be honest with you. You know, our treatment right now. So here's the deal. You know, you extrapolate data coming from the 80s and 90s to 2024, where you have better control of hypertension, better control of diabetes, you have Jardiance, you have the Ozempic, you have the semaglutides, you have a high intensity, remarkable statin, you have Repatha, you have Leqvio, you have a bunch of treatment in your arsenal that what used to apply in 1992 doesn't apply anymore right now. And, you know, we struggle with it all the time that, you know, it's a cardiologist becoming like it's general surgeons. You know, they cut and they do, and then they bunch of antiplatelet, anticoagulation, and then God bless you. It doesn't work this way. Patients suffer from that a lot. And we're really thinning the blood too much in layman terms. It's not acceptable. Triple therapy is not acceptable anymore.
Okay.
No aspirin Plavix, Eliquis, no aspirin Brilinta, Eliquis, no aspirin Effient, Eliquis.
Okay.
Effient, since we mentioned Effient is a black box warning if you have history of TIA or stroke. Be careful about that, okay? Any question about that aspect though? Okay. AV nodal ablation. Usually when you interrogate the pacemaker, there are notes by the reps at the time of implant written as patient has AV nodal ablation, all right? If patient has atrial fibrillation and you interrogate the pacemaker and the pacemaker said 99% pacing, RV pacing, then that's AV nodal ablation. Can we agree on that? Because there's a question about when do we know that pacemaker interrogation, there's AV nodal ablation. AFib, pacer, interrogation shows 99% RV pacing, that's AV nodal ablation. Most of the time, there's actually a note in the chart in the interrogation that patient has AFib ablation. I'm sorry, AV nodal ablation.
Okay.
Okay. If you look at the atrial lead and you see impedance over 3,000, that's AV nodal ablation most of the time, because they didn't use atrial lead. Okay. Indications for Watchman. So number one, patient can take anticoagulation. Okay. Number two, patient can take anticoagulation, but he has or she has higher risk of bleeding, fall, or complications from long-term anticoagulation. Number three, patient does not want to be on anticoagulation, and that's called compliance issue. Okay. Three, bleeding risk, potential bleeding risk, and compliance. Procedures usually take 10 to 15 minutes, pretty safe. They go home same day. It's just remarkably easy procedure. Don't be afraid. There's question about anticoagulation in nursing home patients. Please do not be afraid of starting anticoagulation. Whenever you start anticoagulation, you have to check your kidney function. You have to check your CBC. You have to check your kidney function every 6 months to 1 year. You have to check your CBC every 6 months to 1 year. So get a baseline, get a couple weeks later, and then every 6 months to 1 year. Kidney function, and the CBC. And always remember that don't really be scared of starting anticoagulation as long as you're going to follow up with some kind of testing, and always document stuff like that in your chart. Few words. Patient had the indication chest vascular atrial fibrillation, chest vascular of 4. Patient needs to be on anticoagulation, hemoglobin 9.5, or I'm not aware of a hemoglobin. We're going to get baseline. I mean, you can, if you feel that your patient is anemic, don't start anticoagulation unless you get your A1, your CBC first. But always intervention and reevaluate your management. You don't want to start patient on 5 milligram twice a day of Eliquis, hemoglobin 8.9, and then 3-4 weeks later, hemoglobin 7.1. It's bad. It's not acceptable. That's not good medicine. All right. Anything else?
Back in the hospital for with sepsis, and she had an episode of AFib with RVR. Apparently converted back to sinus rhythm without. Well, I want to say maybe they put her on amiodarone, but my question is wouldn't we just call that paroxysmal atrial fibrillation and put her on anticoagulation? The cardiologist that saw her in the hospital wants a Holter monitor.
No, if you get EKG with AFib, that's AFib for the rest of her life.
Yeah, that's what I thought. Okay, good. That helps me out because I was trying to figure out how we were going to do a Holter monitor out here and, without having her follow
No,
up.
that's AFib. So look, if you catch atrial fibrillation on Holter monitor, that's AFib. If you catch it on EKG, that's AFib. Okay.
Got it.
If you catch it on loop recorder, that's atrial fibrillation, right? Now, it becomes tricky when you look at device interrogation, right? When it becomes device interrogation, I used to tell people that, hey, guidelines says 24 hours or more, that's AFib, you have to anticoagulate. Below 24 hours, then it's up to you, right? There's some data about 6 hours to 12 hours. There's some data about 12 hours to 24 hours on device interrogation, right? But, you have to take it with a grain of salt. So, I'm very aggressive. If I feel more than a couple hours of atrial fibrillation on device interrogation, I would label that as atrial fibrillation, chest vascular my patient, and anticoagulate. But the guidelines is very strict about 24 hours or more. That's AFib. Beyond that, it's up to you as provider. However, if you catch anything on EKG, that's going to be like that too. It's going to be stuck with you for the rest of your life, and you have to educate your patient. You're going to carry this diagnosis for the rest of your life. You cannot reverse it.
Thank you. Very clear.
All right, guys. Anything else? Okay. So keep sending us, questions or topics that will make it much easier for us to, all these questions very, very valid, very good. All right, good to talk to you guys. Have a great evening.